Hey guys, it's Olivia. Welcome back to your endocrinology chapter. In this section, we'll be going over some of the anatomy and the function of your thyroid gland, and this can show up on step 1 in a couple different ways. So first, let's talk about the location of your thyroid gland. Your thyroid gland is going to be this butterfly-shaped gland that is anterior to your trachea and inferior to your cricoid cartilage. So if you look over here in our diagram, you can see we have this butterfly-shaped gland. This right here is going to be your thyroid. It is sitting right in front of your trachea. You can see your trachea with these little rings of cartilage right down here. Then above it, we have our cricoid cartilage. Our cricoid cartilage is immediately above our thyroid. Then we have our thyroid cartilage sitting a little bit above that. So those are going to be our big structures that are surrounding our thyroid. Perhaps more important than the actual structures of the thyroid, however, is going to be the blood supply and the nervous innervation. So starting out with the blood supply, we have our common carotid artery, and our common carotid artery on our right is going to be coming off of our brachiocephalic trunk. So our brachiocephalic trunk on our right will give rise to our subclavian artery and our common carotid artery. Our common carotid artery is going to go all the way up here, and then it's going to bifurcate, and it's going to bifurcate into your internal and external carotid arteries, and your external carotid artery is the one that is usually going to give rise to our superior thyroid artery. So the superior thyroid artery I've drawn here coming off of your external carotid. Sometimes people have a little bit different anatomy, but commonly it does come off of your external carotid, so that is how I have drawn it here. On the left side, this will be exactly the same, with one difference, that our common carotid is going to be coming directly off of the aortic arch. It's not going to need that brachiocephalic trunk like we had on the right side, so our common carotid comes directly off of the aortic arch. It is then going to bifurcate again. We are going to be looking at our external carotid because that is what is going to give rise to our superior thyroid artery. So we have our superior thyroid arteries right there, but then where do our inferior thyroid arteries come from? They come from the subclavian artery. So if you look over here, we have our right subclavian artery. Our subclavian artery is going to be that branch that came off of the brachiocephalic trunk that isn't our common carotid, and that right subclavian artery is going to give rise to our inferior thyroid artery, which will come right up here. That's going to be the same as on the left side, except for the fact that on our left, our subclavian is coming directly off of our aortic arch, but it's still going to give rise to our inferior thyroid artery, and thus both of our inferior thyroid arteries come off of the subclavian artery, and that is how we get supply to our inferior thyroid. Now, why is that important? Well, one reason why that's important is because of these arteries' proximity to the nervous innervation of several muscles surrounding the thyroid. So our recurrent laryngeal nerve, if you look over here, you can see our recurrent laryngeal nerve is coming down. It's actually one of the branches of the vagus nerve. The vagus nerve is cranial nerve 10. So our vagus nerve, one of its branches is going to be this recurrent laryngeal nerve, and our recurrent laryngeal nerve is very close in proximity to our inferior thyroid artery. On the left side, we're also wrapping around our aortic arch and coming up, but then again, we're very close to this inferior thyroid artery. And that's going to be really important for you to understand, because if you understand the proximity of the recurrent laryngeal nerve to the inferior thyroid artery, it's easy to see how during a thyroidectomy or during any ENT surgery in that region, you could have damage to the recurrent laryngeal nerve. Your recurrent laryngeal nerve supplies all the intrinsic muscles of the larynx, so the cricoarytenoids, the thyroarytenoids, your transverse oblique arytenoids, etc., except for your cricothyroid muscle, which is going to be supplied by the superior laryngeal nerve. And this role of the recurrent laryngeal nerve supplying most of the intrinsic muscles of the larynx, those muscles that are responsible for opening and closing the glottis, is going to be really important for you to understand, because then damage to this nerve leads to a very classic presentation of hoarseness and dysphagia. So when this nerve is not working and you're not having proper function of all of those larynx muscles, you can get hoarseness or voice changes, and you can also get difficulty swallowing. This is going to be a very classic presentation. You know, if you've seen a board style question that someone recently had thyroid surgery and now they have hoarseness and dysphagia, it's likely that they had damage to the recurrent laryngeal nerve. So that's the structure of the thyroid, but let's talk a little bit about its function. The job of the thyroid is to combine iodine and tyrosine. I recommend knowing that these are the starting products that will then be turned into thyroxine, T4, and triiodothyronine in your thyroid. I have this little arrow here between T4 and T3 because even though your thyroid does produce T4 and T3, it's going to produce more T4, and then that T4 is going to be converted peripherally into T3, which is more active, more potent form. So your thyroid does release T4 and T3. It probably releases more T4 than T3, but T3 is going to be that more active form, and a lot of our T4 is going to be converted to T3 peripherally. If you understand that the job of our thyroid is to suck up all the iodine it can find and make T4 and T3, then it should make sense that if we have iodine deficiency, we are going to get more growth of those cells whose job is to look for iodine because if there's less iodine to be found, those cells think that they need to do a better job looking for iodine, so they replicate. When they replicate, this is going to lead to thyroid enlargement. And this is going to lead to a neck mass, oftentimes called a goiter. So if you look over here, you can see this woman has a neck mass or a goiter. These are going to be a lot more common in developing iodine-poor countries. These goiters are not always caused by iodine deficiency, but certainly iodine deficiency is one important cause of a goiter for you to be aware of before taking step 1. So we know that the end function of the thyroid is to produce T4 and T3. But how is this process regulated? Well, this process starts out in the hypothalamus. The hypothalamus releases thyrotropin releasing hormone. Thyrotropin releasing hormone then travels to the anterior pituitary. Remember, it's the anterior pituitary that stores and releases thyroid stimulating hormone. Thyroid stimulating hormone, of course, travels to the thyroid and stimulates it to release T3 and T4. And the products, T3 and T4, then go on to exert their metabolic effects in the body, as well as to inhibit the anterior pituitary, decreasing release of TSH. They are also going to inhibit the hypothalamus, decreasing release of TRH. And this is a negative feedback pathway, like the Nike pathway, if you remember from some of our earlier videos. So a classic example of negative feedback here. So that's how we regulate production and release of T3 and T4. But what do they do? Well, T3 and T4, I only listed T3 here because it is the more active form, but T4 also has these effects. T3 and T4 are going to be responsible for regulating metabolism, temperature, weight, muscle strength, and your nervous system. So all these different systems throughout the body. And that's what's going to lead to their widespread effects when we talk about states of dysregulation of your thyroid hormones. That is why you're going to see symptoms in so many different body systems, because of the wide array of jobs T3 and T4 has. So talking about dysregulation of our thyroid hormones very briefly, I just want to give you guys an overview of the clinical pictures of hyper and hypothyroidism. So first, let's talk about hyperthyroidism, when we have too much T3 and T4. And to understand the effects of hyperthyroidism, first I want to direct your attention to our hyperthyroidism friend down here. And there are two main takeaways that I want you to remember about this picture. Number one, this is a picture of someone who is hyper. This person has too much energy, as you can see on this little battery that is all the way up, and you can see it by the Red Bull that they're drinking. So think of someone who's really caffeinated. They have a ton of energy. They might be having heart palpitations. They're moving really fast. They can't sleep because they have too much energy. They might be anxious. They might have tremors. All these things that go along with either being hopped up on an energy drink or having too much thyroid hormone in your body. Additionally, when you think about hyperthyroidism, I want you to think about a person who's incredibly metabolically active. So we are burning through a ton of calories. You can see that this guy is running. He's also overheated and sweating. That is what happens when you are burning a ton of calories and giving off a ton of energy, is your body starts to heat up. And if you can remember this little picture down here, I know it's silly, but I think it will help you remember all of the clinical symptoms that we see with hyperthyroidism. So number one, we're going to see our heat intolerance and diaphoresis. Remember, our guy was sweaty. You'll see weight loss and diarrhea. Things are moving fast. We are really metabolically active here, so we're burning off all those calories, losing weight, and things are passing quickly through him. So we have diarrhea. There's an increased fracture risk with hyperthyroidism as well that comes over time from some hormonal changes. Additionally, remember hyperactivity, restlessness, insomnia, anxiety, fine tremors, heart palpitations, or even hypertension. All these things you could see if someone took 7 energy drinks, which is why our little guy down here has a Red Bull. And then finally, you might also see gynecomastia in males or abnormal uterine bleeding in females who have hyperthyroidism. And then by contrast, hypothyroidism is going to present with decreased T3 and T4. And if you look down here and see our hypothyroid friend, you can see that this is kind of a directly opposite presentation of our hyperthyroid person. This person is metabolically inactive. They only have 1 bar on their battery. And because things are moving a lot slower for them, these metabolic processes have slowed down. They are going to be, number one, cold, because they're not burning through as much energy or releasing energy to heat their body. You can see that this guy has a little bigger body habitus as well. Weight gain can also be associated with hypothyroidism because you're in a more metabolically low state. You're not burning through as much energy. You'll notice that this guy, instead of running, is laying in bed. That's because you might see some fatigue, weakness, or lethargy, just generally lower energy when you have hypothyroidism. So keeping this picture in mind, we'll go back to our symptoms of hypothyroidism. Cold intolerance and weight gain, we talked about those. You have this guy who's shivering under a blanket and has a larger body habitus. You might see dry skin, coarse, brittle hair, brittle nails, or constipation. These are going to be symptoms that are going to be important for distinguishing hypothyroidism from other diseases who can present similarly, like major depressive disorder or anemia. And then you might also see fatigue, weakness, lethargy in patients with hypothyroidism hypothyroidism. This guy can't even get out of bed. He's so tired. Decreased reflexes, and then additionally bradycardia. So exactly the opposite of those palpitations and tachycardia we saw in hyperthyroidism. So I know that was a lot of information. Let's briefly recap what we talked about in this video. I think the most important anatomical pearl to be aware of in regards to the thyroid is that the recurrent laryngeal nerve, which supplies all the intrinsic muscles of the larynx except for the cricothyroid, runs really, really close to that inferior thyroid artery. And because it runs close, it is prone to be damaged during a thyroidectomy or other ENT surgery, which can lead to the classic presentation of hoarseness or dysphagia. I think it's also important to be aware of this negative feedback loop that regulates the release of our thyroid hormones. And then I think it's really important for you guys to be aware of kind of the classic presentations for hyperthyroidism as well as hypothyroidism, and keeping these straight in your head before we dive into some of the more specific pathologies that can cause each of these presentations. Now, how would they ask you about this in a board style question? Well, something they might ask you is, a 15-year-old patient is brought to the physician by her parents for unintentional weight loss, diarrhea, palpitations, and increased sweating over the past month. Her father is concerned that the patient is taking drugs and requests a urine drug screen. Urine drug screen is negative, but T3 and T4 are elevated. The patient undergoes thyroidectomy to treat her underlying condition, and you see her for her follow-up appointment. At her follow-up appointment, she is recovering well, but she has begun to experience some hoarseness and difficulty swallowing. The nerve most likely responsible for her symptoms innervates all of the following muscles except which one? So in this presentation, we have a patient who is coming in for increased sweating, some unintentional weight loss, and diarrhea. Her dad thinks that this could be due to the fact that the patient is consuming drugs. And certainly if you were a patient taking maybe cocaine, you could see a lot of the symptoms of hyperthyroidism, right? You could see palpitations, weight loss. You might see a person who is really restless or anxious. It could present a lot like hyperthyroidism. But most recreational drugs will not cause this elevated T3 and T4. That's what makes it more concerning for a hyperthyroidism. We don't entirely know what is causing her hyperthyroidism, but we do know that she was treated with a thyroidectomy, and that after her thyroidectomy, she began to experience hoarseness and dysphagia. And these are going to be classic symptoms for a recurrent laryngeal nerve injury. So we're pretty sure that's her pathology. And the question asks us that the nerve responsible for her symptoms innervates all of the following muscles except which one? Because it's the recurrent laryngeal nerve, and there's one very important exception to be aware of, I would be scanning the answer list for the cricothyroid muscle, because that is going to be the only intrinsic muscle of the larynx that is not innervated by the laryngeal nerve, but is instead innervated by the superior laryngeal nerve. I hope this video was helpful, and I'll see you next time.